hospital. Mike is the acute medicine team lead for the acute medicine unit, and then Lorraine is the ER project lead. And they'll get into the discussion today about what actually ED-PIP is. And we were talking before, and I said, well, keep it, I don't use a lot of acronyms, and we looked at the screen and said, no, that's not. But that's Emergency Department Performance Improvement Process, and it's about improving the processes within emergency departments. And we actually we started off funding University Hospital in London. It's now expanded out to include Victoria Hospital in London, St. Thomas-Elgin General Hospital, and Owen Sound Hospital in the Southwest LHIN. And the purpose of this project is to drive down wait times in emergency departments and then free up beds within the hospital. And they'll go through all the details, so welcome Mike and Lorraine.
We're going to go through the presentation. In May, we did a value stream map of from emerge, from the time the patient arrives to the time they're discharged and emerge, or if they're admitted into the acute medicine until they're discharged. Again, high level, this is basically the patient's steps and processes, wait times in between each process. And as you can see, there's some highlighted areas from 0 to 120 minutes between certain processes. As you see down here, admit hours to days. So what the team did is we had physicians, OT, PT, we had everyone in the hospital sit down for about 6 hours and look at the patient journey from the time they walk in the door till the time they leave. Then we highlighted some areas where we needed to work on. We drilled down a little further into what we need to work on in emerge and in the NU. And again, some more highlighted areas, 40 to 300 minutes, 0 to 480 minutes of wait time in the acute medicine. What we've done is we've compiled a DART, the Daily Access Reporting Tool, and on here it is a daily automated version of discharges, the amount of patients that's seen and emerge day to day, 7 days up to 30 days. And our measurables from discharges at 11 o'clock mainly to 2 o'clock to average length of stay for admitted patients and emerge patients. So this is the tool that we use each and every day that we measure part of our successes of.
What's really important about this tool as well is it's color coded, because red means, wow, we're not doing so well. Yellow is we're kind of in a caution area, and the green is we're really meeting the metrics or the targets that we had set for these specific measures. And it's really helpful because the reason it's important to have a daily tool is that we can remember what's happened the day before that might have changed those numbers. And we can then know more what we need to fix if there's a problem. So much of our data that we have is month old, sometimes even 3 months old that we have looked at in the past, and the daily data is really helpful for us that way.
And if we meet the target, in some cases we are meeting the target, the beauty of the process improvement plan is we'll change the target, and we'll either lower or raise the target. So in this case, average discharges by 11 o'clock is 20%. We're at 19.2, so if we consistently hit 20%, then we'll raise that to say 25%. So we're constantly improving the processes. So early on there's 4 phases: the diagnostics phase, let me get these right here, solution phase, implementation, and the rollout phase. And early on the diagnostics phase, what we did from each group is we go to gamma. We went and seen the problems, and we collected data. This is data we collected by Pareto, basically just check marking reasons for discharge delays, some of the reasons. And again, with the process improvement is one of the issues was no orders written. Everyone thinks of the physician, but why weren't the orders written? So we drilled down and found out it wasn't necessarily the physician. It could be family members. It could be waiting on test results, etc. So again, looking at the data in front and drilling down each specific piece of data. And again, with the admissions and discharge patterns, if you look here, from noon to 3 o'clock, we had a large percentage of discharges, but in emerge, the amount of admissions spiked at the same time. So we were trying to get people out discharged in a timely manner, but people were coming up from emerge at the same time. So we didn't have any time to clean rooms or, get the people discharged in a timely manner. So that was another issue.
In the emerge, we found that our supply and demand didn't match. So what that means is we had the multicolored kind of is the patient arrivals by CTAS level, and what that is we actually categorize our patients based on how ill they are, and we assign them a code, a 5-level code. So that's kind of what the numbers are going up, and then really the times that the volumes are arriving. So we found that we actually had the yellow line kind of across the side is when the MDs come, and the black line across the top is when we had our RN staff. So we found that we had excess patients already building up in the waiting room at 9 o'clock in the morning, yet we didn't upstaff until 10 for the docs and 11 for the nurses. So we were already kind of behind the 8 ball, you know, as far as getting patients in and seen because we didn't have the resources available. So we knew that was an opportunity we could work on. The next one was, we really found we had this long waiting period, particularly for our CTAS 4s and 5s. And those are the kind of people that, you know, they need to see a physician, but they can safely wait for 60 minutes or longer to see the doctor. So sometimes, you know, we don't focus on that group, or we're, you know, we obviously we want to, you know, help the people who are the sickest when they first come, but we also need to, how can we meet the needs of this patient population as well? So we really wanted to kind of find out how we could improve this time, because really these CTAS 4s and 5s are actually 42% of our patients. So it's a large group of patients that we really need to, you know, get through the system, get them in, get them seeing the physician, the treatment they need, and then home if that's what is where they need to be. So that was another focus of our work. One other thing that kind of came is, as far as the daily data, I told you how important that was. But we also had a struggle that we were having in our emergency department of just discharging our charts. Because sometimes there was, you know, you didn't have, you know, the busy environment, you didn't always have time to kind of finish what you needed to write, or it got kind of stuck here, then you had to go on to the next patient. So we really struggled with just getting with our chart process. So we actually had a secondary little team that worked on just focusing on that problem. And we found out, we used to think it was those doctors, you know, they just didn't finish their charts, they stuck them and hid them somewhere, and you know, we kind of thought that was what we thought was the problem. But when we drilled down, we found out actually that 80% of our charts were actually all complete, all the documentation was there, but no one had had the physical time to sit at the computer and discharge them. And that was the first 3 groups we found when we actually just collected data on it. So it wasn't the bad docs, it was just the fact they were in a place and no one had that next step. Some of that was because we reconfigured some of our workload and, with other departments, with our client services. So we had to kind of see then how can we solve this and work through that problem. We also found we had duplication of our process in this chart flow. We actually had 3 different departments doing the same thing. And so either was a trust that the earlier ones didn't do it, or there wasn't really a clarity in what the steps were. So that was also part of the work we did.
So in the solution design phase, the team looked at all the data collection, the value stream map, and we come up with 4 or 5 items in each department that we were going to work on. On the inpatient side, we were going to reassign and apply extra stock rooms. So we added an additional stock room on the 5th floor to save steps for the nurses and standardize both stock rooms. Isolation parts of patties, although it may not help the length of stay, but as far as getting food to the patient in the right time, actually it helped a few processes with housekeeping, kitchen staff, nursing, and the patient. All of those were directly affected by us changing our isolation parts, or are in the process of changing them, I should say. Equipment master plan, we looked at a standardized equipment room for all of the patient equipment for 4th and 5th floor. So we rearranged basically the whole floor in acute medicine to standardized 5th and 4th floor, so they're identical. And we found a large space for patient equipment, so the nurses knew to go to one spot. It was repaired, it was plugged in and ready to go, and it was clean. Bullet rounds and nurse patient whiteboard, they kind of go hand in hand. This is where, I shouldn't say we struggle, we continue to improve. We've set up what Flow Collaborative did years ago with a bullet round board. We've relocated it, we've improved it with allied health, OTPT, the nurse physician, and the MRN. And we do our bullet rounds in the morning, and in the month of February, we're going to focus on discharges for the bullet rounds and patient information, where the right amount of people will be there, physician, the unit leader, and some allied health. Look at the patient information and what barriers to discharges there are today for that patient to get them the right care and the timely discharge. And nurse patient whiteboard, again, each room has a small whiteboard with patient information. So who your nurse is, the date, your expected date of discharge, OT/PT information. And the idea is for the nurse to bring that information to bullet rounds, or from bullet rounds to take that information back to the patient. So those two whiteboards correlate with their expected length of stay. So the patient has an idea of what's in store for them between now and their date of discharge. Oh, sorry. Lorraine.
What we really found out again when we talk about those CTAS level 4s and 5s is we wanted to establish a way that we could look after the same patient population but in a different way. So we established what we call the Rapid Assessment Zone, or the RAS, was kind of what we called it. And what it did is we actually had a very specific inclusion-exclusion criteria that the triage nurse would assess the patient and based on this criteria decide if they were safe enough to go to this separate area. So what it was, it's staffed with a nurse and a physician that's dedicated to that area, and then what they do is they expedite those patients through in a separate process. And the idea is that we can kind of divert their care to this specialized area with dedicated resources, then we actually free up space in the main department. So we can actually better service our more acute patients. So that was kind of the idea that we started with the trial, and it's worked very well actually most days. There's some days when you have high acuity and high volume, it doesn't work as well because again you don't have the patients that would meet the criteria. Room allocation, RN assignment, we really wanted to balance our workload. We found we had some nurses that were we had a very linear assignment structure where we made it more pod-like, kind of like your kitchen triangle. We thought that would work a lot better. It works at the home. Why let's not try it in our department? And really, nobody even called the names. We had issues where we had 3 OR1s actually in the hospital. We had one in the emerge, we had one in the operating suite, and we also had one in the ambulatory care department. And so if a code was called, there was sometimes we'd had times where there was confusion on actually where to go. So we now just call them rooms 1 to 9, and really we wanted to promote a multifunctionality of those rooms where we always had this idea that only certain things could happen in this room, and only certain things could happen in that. And we really wanted to be able to use our rooms better and more efficiently for all of our patients, and that way we wouldn't have people waiting in the waiting room. Well, we have to hold you because we need this room. So that was kind of our rationale there. Essential supply room and equipment, we had actually 3 separate supply rooms in our department. Again, it's an old facility and it's been reconfigured over the years, so we had some challenges there. And we really wanted to have it so it was one-stop shopping. And particularly when we have a lot of newer staff coming on board, it's like, where do I go? Is that in the front, in the middle, the back? And just how could we get it all together so we could have one-stop shopping? So we actually kind of thought outside the box and met with some challenges, and we really had to do some research on this, but we actually took one of our big treatment rooms and made it into one centralized stock room, so people would just know to go to one place. Standardized bedside and carts, we wanted to have every room look as much as possible the same, so that you would really, you could just grab the equipment you need from a bedside cart that would be the same beside every bed, and then when you can do that, you can concentrate on your patient, because everything's so automatic when you know where things are. So that's the other thing we worked on. And improving our chart flow, and I already kind of talked about how we were working on our chart flow, so we'd have good daily data. Because if the charts aren't discharged, our data's not going to be very good.
So, the pilot phase, we took all those ideas and we started to pilot them throughout the units and emerge. As far as discharge planning goes, I'm not going to read this verbatim here, but the idea with our discharge planning is with the bullet rounds, is getting the right people there, the right time of the day, to understand what is going to happen in the acute medicine department from 8:30, 9 o'clock to the end of the day. And again, that affects housekeeping, the physician, the nurse, the kitchen, the most responsible nurse, everybody. So at the end of bullet rounds, we know what's going to happen on the department with discharges. There might be 8 or 9 discharges that day. So again, everyone that I just mentioned is directly affected by those 9 people throughout the rest of their day. Actually, that's what I want to say with that one. Now, the DART here, unfortunately for the acute medicine, the average length of stay has gone up and down. It's increased and decreased. The discharges by 11 o'clock and 2 o'clock really haven't seen a great deal of improvement until the last 2 months. So what has happened up on the floor, discharges by 11 o'clock, we've exceeded the target. We're at 24.2. and we're within 25% of the 2 o'clock, we're at 50.5. So 75% of the people are getting discharged by 2 o'clock. So we attribute that to better facilitated bullet rounds. So we've improved the coordination of patient care and discharge planning to reduce the length of stay and improve discharges. Again, the length of stay is still, it's up and down. It is improving though. What we did with the acute medicine on 5th floor, we lowered the patient count from 36 to 31, and on 4th floor, we raised from 21 to 26. So we balanced out the patient load for those 4 floors, or for those 2 floors, I should say. And again, some of the solutions, we introduced a modified whiteboard. On the right-hand side, we just took what the Flow Collaborative did a few years ago. We relocated the board so it was more visual. So this board on the right is 24 hours updated. So if you're OTPT, the physician, the nurse, your responsibility is to update that board. It has the room number, the patient name, it has the nurse assigned to that patient, it has all the LA Health, it has the physician's red team, blue team, their names. The census on the top is patient transfers, on the side, transfers, discharges, and admissions. So this is kind of a live view of what's going on the floor. We have one on both 5th and 4th. So what we do in the morning is we look at your green is within 24 hours, your yellow is 1 to 2 days, and your red is 3 or more days for discharges. And we want to hone in on what's the barrier to discharge for this specific patient today. So what's keeping this patient from going home? And the one on the left, again, is the patient whiteboard in the room. So that's what it should look like in the patient room. And the nurse has that conversation, OTPT, with the patient each day. And the discharge date on the patient whiteboard should match the one on the bullet round whiteboard. So those are the 2 boards we want to pull together and, again, have the MRN bring that information to bullet rounds and from bullet rounds to the patient. One of the other things, although it may not decrease the length of stay, but if you look on the left, there's a current hallway on the 5th floor. You see food trays, isolation carts, lots of excess stock. We want to go to a more wall mount isolation caddy. It looks a little different than this, but one for every 2 to 3 rooms. So we limit the amount of stock in the hallways. We limit obviously some hazards from the fire department as well to get out, and it cleans up the hallway a little bit better. As you can see on the left, what happens is with these isolation carts is the kitchen will bring up the tray of food and they'll set it on the cart. And then the nurse will take it to the patient. And then from the patient back to the cart, and from the cart to the kitchen. So by going to this one on the right, we've actually assisted the kitchen and the housekeeping as they actually pick up the trays and the nurse. So you make the food, you deliver the food, you pick the food up, and you return it to the kitchen. And then nursing focuses on the patient care. So actually, there's the before and after, and this is not by any means staged. This was taken from the manager one particular day. And one of the I shouldn't say problems, but one of the hurdles we face is a change of culture. It'll never happen. You'll never get the hallways free of debris and stuff. Well, there's a before and there's the after. And these were all shots that we've done during the pilot phase. We just went out with a camera, started taking pictures. We videotaped a few things, and that's the before and after. So we're pretty happy. It doesn't look like that every day, but that's what we want to get to. That's our goal. The top picture is the equipment room. We basically took another hurdle. This used to be the nurses' staff room, and we relocated the nurses to a smaller staff room, and we fit in their OTPT wheelchairs, all your patient lifts, isolation caddies, curtains, and that's what our equipment room should look like each and every day. And we audit this every day. The manager, the nurses, ourselves audit this and put things back. And this is going to get filtered down to the staff every day. We'll be auditing now. So everything's plugged in, everything's working, and the nurse knows, here's where I go to get my equipment. I don't have to go down to the next floor or the floor above me. So.
For Burge, again, as I said, we established the rapid assessment zone. And really, again, diverting that stable ambulatory or self-propelled if they can move themselves in a wheelchair. So those are the kind of patients can go. And those who really don't need to have extensive tests or need to lay down. So that's the basic criteria. If you meet that criteria, you have stable vitals, you can walk or get there by yourself in a chair, and you don't need extensive tests, and you'll be diverted to the rapid assessment zone. So really our opportunities, we wanted to reduce our length of stay for all our patients we wanted to reduce our left without being seen, because if people wait long times, you know, they just say, I can't wait any longer, whatever challenges they have, they may leave, and that's a bad thing, because we want to be there to care for our patients, and we want to meet their needs. We wanted to reduce our time door to doc. So that physician initial assessment, which is what PIA is there, is really, you know, how can we get, I mean, people, you know, they're happy to see the nurse at triage, they're happy to see the nurse when they bring them in the room, but they really came to see the physician. So how can we make that happen sooner? So that was part of the goal as well. And really improving the admitted patients with a length of stay in less than 8 hours. And that's where we're collaborating with the acute medicine team, is we're actually trialing, kind of in the middle of a trial process of how can we get patients to the floor faster. So it was something that kind of came at the end of the project, and we've extended the project actually so we can kind of continue that work. And we really wanted to realign our assignments, as I said, and make the rooms multifunctional. And you can see actually this, the results that are on the screen here are from our pilot, which was September 13th to October 27th. And we actually met all of our targets in that period of time, and improved our door-to-doc time by 30 minutes for all CTAS levels. And so we were pretty pleased with the results. And so really the trial is over, and the rapid assessment zone is part of our regular practice now. The other thing I talked about was that ER chart journey. That's really, we wanted to have the health record safe, because if it's not discharged, then it's not in health records where it's safe. So that was really the big goal of this. So really 1 month pre-trial, we actually had 44.8% of our charts that were discharged on a daily basis. We actually did a mini trial and got it down to 22.9%. And then we actually stabilized at 14%. So that's pretty awesome. Unfortunately, in the last little while, we've had some changes again. With our merged construction, we've changed the location of our client services clerk. So we've met with some challenges there. So we kind of have to meet again and say, how can we tweak this process to kind of get it back down there again. But still, at least we know where the charts are, because we used to have multiple people running around looking for them. So it's really streamlined our process and made it a lot less, and very safe for the record. That's what's the most important.
Okay, so what have we learned, and what benefits have we seen from participating in PIP? We met with the executive team, the staff, and the team itself, and we went through, you know, a little lessons learned. We still have some ways to go, and we still have to do a few more conversations about lessons learned. How will we sustain the gains? And again, that's why we've extended the program for at least 3 months, because we need to start to sustain what we've done. Just to walk away after 9 months, probably within weeks, it would be back to where it was. We're currently working with managers, unit leaders, and staff right now to look at the metrics, get into daily, weekly, and monthly audits, and have the conversations with the staff members from the management side of what we're doing well and what we need to work on, and involving the staff day to day of how they contribute to all these metrics and how to improve those metrics. Again, one of the other things, again, I mentioned the 2 to 3 tier audit system. So right from the executive team down to the staff, you would have audits that take place again daily, weekly, monthly, and the Paul Collinses would come do an audit and emerge, and ambulance or acute medicine, the managers on a weekly or daily basis, depending on what